Yeah, in the earlier talks, we had a look how do we plan for the surgery, how do we execute a perfect pediatric cataract surgery. Now we are going to have a look what all adverse outcomes we can encounter during the surgery as well as after the surgery, and what can be done to manage them well or better to prevent them. So this slide lists all the possible complications that can happen during pediatric surgery. We would only be dealing with more common ones and more important ones. Incision-related problems, like mentioned earlier, pediatric eyeballs are soft eyeballs. The wounds are not self-sealing. Hence, it is very important that we make smaller wounds. Better to have tunnel configurations rather than direct stab incisions, and always important to suture off each and every wound, be it even as small as a side port. Coming to problems during capsulorhexis, we all know that pediatric anterior capsule is very elastic, and the younger the child, more elastic the capsule is. So that is why we have now shifted on to vitreorhexis, that instead of doing the anterior rhexis with a rhexis forceps, we have now started doing it directly with a vitreous cutter. So the technique is very simple. You inflate the anterior chamber with a high viscosity OVD, and using the cutter with the port facing downwards, you just engage the capsule and cut it, make it into an opening of your desired size. It is better if you have access to a Venturi machine, but it can also be done with a peristaltic machine. Sometimes we may encounter a situation like this where the capsule is all fibrotic and has a subcapsular plaque below that. In such cases, it is very difficult to initiate the puncture in the center. It would be worthwhile in such cases to make a incision towards the periphery of the capsule and then start pulling the capsule as you would do in a push-pull technique. So we are grabbing hold of the capsule, but you can see because of the dense plaque, it is difficult to hold it with the rhexis forceps. So there has actually been a paper where they have described that this plaque can actually be used as a template for maintaining the size and shape of your rhexis. Intraoperative meiosis. The pupil may remain small in spite of all your aggressive preoperative eye drop regimen. That is because there might be congenital anterior segment maldevelopment, or if during surgery you accidentally happen to touch the pupil, there is going to be sudden meiosis. So to prevent that, it is recommended that 0.5 ml of 1 in 1000 adrenaline should be used in the irrigating fluid. And like sirs described, you could also use one of these devices to dilate the pupil. In rare instances, there may be an inadvertent rupture of the posterior capsule. Even before you want to rupture the capsule, you might notice that the PC has ruptured. So if the PC tear is small and in the center, you can go ahead and convert that into a posterior capsulorhexis. If it is not possible, you can go in with your vitreous probe and make it round and proceed with in the bag IOL implantation. Here, this video is showing IOL implantation followed by posterior capsulotomy and anterior vitrectomy through the pars plana route. So the advantage of this approach is that your IOL is already in the bag and you're not concerned about making the PC opening too big. So you can afford to be more aggressive. In addition, there is no vitreous coming into the anterior chamber. So you are very unlikely to leave a vitreous which is attached to your wound. So the site of the pars plana wound would depend on the age of the patient as well as the axial length of the eye. Sometimes you might encounter situations like this, where after removing the cataract, there's a dense PC plaque. In many such instances, you will be able to create a cleavage plane between the PC capsule and the plaque. You can dissect the plaque through this plane and take it off, like in this case. Even after taking off the plaque, we notice that the PC is opacified primarily. But this can easily be tackled by doing a PC-tomy and enlarging the opening with a vitreous cutter. Zonular dialysis, this is more common in traumatic cataract, or if we are not gentle in doing the surgery. Whenever you encounter such a thing, it increases the risk of vitreous loss as well as loss of lenticular material into the vitreous. Problems with intraocular lens complications, there may be malplacement or malpositioning of the IOL on entry of the eye. Especially with the rigid PMMA lenses, it is very possible that the trailing haptic may be left behind in the sulcus instead of being in the bag, or there may be displacement of the IOL through the PC opening into the vitreous. So to prevent this, doing the PC-tomy and anterior vitrectomy after implanting the IOL, as shown in this video, or using the pars plana approach to do these steps would be a better technique. So you can use your second instrument to lift the IOL anteriorly so that you are able to do all the maneuvering more easily. So in my hand, this is a much safer technique, and it almost eliminates the risk of losing the IOL through the PC opening. Postoperative anterior uveitis is very common in kids. This is because they have an aggressive healing. So to reduce this, different authors have described different techniques. People have used heparin in irrigating solution. People have used heparin surface modified IOLs. People have used a recombinant tissue plasminogen activator to take care of the fibrinous reaction that often accompanies pediatric cataract surgery. To prevent that, the most important thing is to limit iris manipulation and make sure that your IOL is in the bag and not in contact with any of the uveal tissues. Fortunately, the most dreaded complication of cataract surgery is rare. One study reported about 7 cases in 10,000 surgeries done. These are the normal or the usual pathogenic organisms isolated. To prevent that, preoperative topical antibiotics, and probably more important is povidone iodine in the eye just before surgery. Capsular. Okay, secondary membrane formation. You would often come across such instances, especially in young child where IOL has been implanted. We do not know whether PC-tomy was done, and the child comes to you with a secondary membrane. So in such a case, you have to go back inside the eye. You have to reach behind the IOL, use a micro scissors, make nicks into the membrane. Try to make this opening as big as possible, but maintain a rim sufficient enough so as to ensure stability of the bag. So once you have made nicks, you can easily go in with your cutter and enlarge that opening. Pupillary capture is again very common. In very severe cases, it may warrant IOL exchange. Deposits on the IOL, fortunately, is not visually significant in most cases and can be left behind. Delayed opacification is seen only in hydrophilic lenses, and fortunately, with the use of hydrophobic lenses in children, this complication is on the wane. Thank you.